Hello, everyone. So here's the project we're going to share with you today that helped us to set out vaccination strategies against measles adapted to the local settings in the DRC. In the DRC, there are recurrent epidemics of measles associated with very low coverage and lack of resources. In the context of our Urgepi project, MSF-OCP has been carrying out immunization campaign together with the MOH in the former Katanga region, which is one of the most affected. The objective being to prevent and reduce the magnitude of the outbreaks. What is difficult with this is that we want to get satisfactory vaccine coverage. In the past, out of 9 health zones with vaccination, 3 were victims of measles outbreaks. Now, thanks to our quality-based studies, we could show that this is due to factors that are specific to each health zone. Now, despite our resources, we are also faced with vaccination difficulties. With the Urgepi project, we've tried to improve our vaccination campaigns. And more precisely, we wanted to look at how we can improve vaccine coverage by targeting precisely non-vaccinated children to avoid revaccinating those who were already immunized. Now, there are 2 types of context. Context without epidemic, but also context settings where there are active epidemics underway, such as in one of our settings in 2025. We have explored the following approach. We have carried out vaccine coverage surveys with questions to know more about the social and demographic data, and also some mixed-based studies with individual interviews with parents, community health workers, and community leaders. These 2 studies, these 2 types of studies are carried out for approximately 1 week. This is the preparation for 7 to 10 days, and then we carry out vaccination over a 5-day period. And then post-vaccination, a new survey is carried out. In our vaccination coverage surveys prior to vaccination, we have found that it was 64% in Ankoro, 79% in Kibalo. The 2 zones where they were preventive, and 75% in Wamba and 70% in Bukama. Now, things are very heterogeneous in terms of vaccination coverage in these health zones. And we also looked at the obstacles to vaccination, but this is going to be explained to you by Nima. Now, in the community, there are several obstacles. There are also, for instance, armed and customary conflicts that lead to displacements of parents with their children, and several parents travel with their children for many days or many weeks because of their needs in terms of agriculture or trade or fishing, and therefore children are not vaccinated on time, also because of the religious beliefs. And parents, for some of them, do not know, are not well informed about vaccination. There are also obstacles in the healthcare system itself, because the routine vaccination opening hours are not adapted to what parents can do. There are shortages, also disruption of the cold chain, and also community health workers report that they are faced with difficulties in organizing vaccination. There are also some structural obstacles. because these are remote areas, and also during the rainy season, it becomes very difficult for the teams. And also, people are not well informed. For instance, there are some health zones without any radio system, or when they have one, well, the households cannot get access to radio channels because they don't have any device to listen to the radio station. So it's important to identify the obstacles that are common to the four health zones. For instance, religious belief was an obstacle that was fairly high in Ankoro, and 8% of participants declared that they didn't want to get vaccination because of their religious beliefs. Likewise, during our qualitative interviews, we have learned that the Star Wars disciples are against vaccination. Their religious belief is contrary to vaccination because health and protection are in the hands of God. And whenever they accept vaccination, well, they are afraid of being shunned or being driven out of the group. So Star Wars religious leaders were then contacted and involved in the vaccination approach. And this is how some children could be vaccinated through door-to-door or outside their village, so as to keep this very discreet. In the Lamba health zone, during the survey, approximately 5% of participants said they didn't want to get it because they thought it was not efficient. During interviews, parents said they didn't believe in the efficacy of the vaccine. And this was also supported by the fact that some parents argued that measles kept coming back and despite vaccination, whereas it was not the case with smallpox, for instance. So because of these concerns about the vaccination, we decided to have a Q&A information protocol based on their concerns. The fear of side effects was more often mentioned during qualitative interviews. Parents are afraid, mainly because for parents, they feel that when there are some side effects, it looks like measles itself. And secondly, for parents, whenever the children are vaccinated, they are going to run a temperature. And if they run a temperature, they're not going to be treated free of charge in the health center. In order to allay these fears, we have made available paracetamol in each vaccination site. Now, in this chart, you can read about what we did on the basis of the surveys. Like, for instance, the concerns about post-vaccination effects and also denial of vaccination because of religious belief. We tackled these obstacles, and for the rest, for the other obstacles, we extended the working hours of vaccination sites, and we also put in place a mobile site for vaccination because of the distance that was considered to be an obstacle. And in order to deal with the traditions, we relied on community liaison officers to take this into account.
Pour récapituler, les enquêtes de couverture vaccinale nous ont permis d'identifier.
To summarize, with these coverage vaccination surveys, we could identify areas where it is under 70% in red and orange here on the map.
Prioritairement pour la vaccination.
So we gave them priority for preventive vaccination. And there are also areas that are recommended by the MOH and shown in blue here. And for response vaccination, we gave priority to the areas with low vaccination coverage, but all areas were covered by vaccination. Now, for mixed-based studies, for each context, specific strategies based on the obstacles to vaccination were developed. With these new strategies, it was possible to vaccinate more than 170,000 children aged 6 to 59 months in these 4 areas. And whenever possible, we also offered other vaccines, such as BCG or the pentavalent vaccine. And following vaccination, we assessed the efficacy of our tailored interventions. So we compared coverage before our tailored interventions, i.e. vaccination associated with OPI, and also we compared it with the former vaccination by MSF, and for Ankoro, coverage went up from
en réactive, à Luamba, la couverture est passée de 64.
In Kabalo, it went up from 86 to 93%. In Luamba, from 64 to 92. In Bukama, from 57 to 85%. So it was. We were able to gain as much as 27 points. And this was the increase was more marked in reactive vaccination versus preventive vaccination. Finally, we also looked at the long-term impact of vaccination. So we looked at the number of cases reported in the national surveillance system. For preventive vaccinations, we could not avoid cases during the major outbreak in 2025. However, it was not as high as expected. When we looked into these cases, well, we could see there were in areas that had not been targeted by vaccination. Moreover, some cases were younger than the targeted age group or were not born at the time of our intervention. Finally, we could show that some of these cases were due to an influx of people from neighboring health areas who had arrived after the vaccination campaign. Now, we don't know about the longer impact for reactive interventions. To conclude, we can say that thanks to our surveys, we were able to better understand what we can do in order to improve vaccine coverage. Also, how to better target non-vaccinated children. And so we were able to adapt conventional vaccination strategies. We could also improve the health promotion actions and community engagement through different stakeholders, parents, community leaders, health workers. And we have also used door-to-door nocturnal or vaccination at night and distribution of paracetamol. These are innovative interventions to lift the reservations to vaccination. However, with the geographically targeted preventive vaccination, we were not able to prevent or to rule out outbreaks completely. However, this reduced their magnitude. And the outbreak response vaccination could put an end to the epidemic. There are challenges, though. Logistics, security challenges, like the cold chain, and there are also very tight time frame to carry out vaccination. However,
les stratégies de vaccination
our vaccination strategies produced valuable outcomes. Indeed, we could not prevent epidemics completely, but we could reduce their scope, and outbreak response vaccination helped us to put an end to the epidemic. And it's also something that can help us to produce recommendations for the teams with questionnaires, with a list of things you can do in order to lift obstacles, and also target their messages to promote health. And these tools can be shared and reused every time we carry out a vaccination campaign. With regard to the, in light of these results, we think that we need to move away from conventional vaccination practices and find some time to take ownership of research findings. For instance, we could organize simulation before interventions to promote innovative response by the teams. We could also simplify research procedures so that they can be directly used by health promotion and vaccination teams. When we target the health areas, it is important to take into account what is the population mobility in order to take them into account in the vaccination strategy. During an outbreak, some health areas had good pre-vaccination coverage, and we can say that this survey did not enable us to have a proper assessment of the children's immunity. And we need to explore new approaches to identify pockets of non-vaccination. In 2025, we worked with teachers, and we asked one teacher in each village to assess the vaccination coverage. And this was very valuable because it gave us something much more detailed. Now, with regard to routine vaccination by the MOH and partners, we suggest the use of tools and recommendations based on the studies, so as to guarantee sustainability of locally adapted strategies and also through pre-vaccination rapid mixed assessment. Finally, cooperation with the MOH and partners is necessary to make sure that the routine vaccination works well and we prevent the onset of occurrence of new cases in the long term. Thank you. And thank you to all our colleagues for their support and contributions. Thank you.